So we're going to be presenting today over optimizing primary prevention of cardiovascular disease in an underserved population, which is, our clinic is located in Newtown, which is about 10 minutes north of the hospital from here. And the population there is, as implied, underserved. They've needed primary care there for quite some time, and that's where our clinic is located. So this is the actual clinic. This picture was taken on the day of the grand opening, which was a very hot day. But it was taken, so this is all 13 residents, including in the middle our program directors, Dr. Lisa Ramesh and Dr. Karen Hamad, who was sitting here up front. And then of course some of the faculty, and then our clinic director here, Ms. Vita Farhangi, right here. Sorry. So essentially, since February 1st, we've received roughly 1,129 visits, which has far exceeded the number of visits that we expected to see. Actually, since the clinic was new, we only expected to see approximately 1,100 visits through the entire calendar year. And from February 1st this year, we've already seen 1,129, which just goes to show the huge impact that we've had on the community thus far. Because we see patients from the hospital, and we also have patients come directly from the clinic, but now they have primary care there, and they continue to come back to us. And so, essentially, the type of pathology that we see here, most of these are the really high risk factors from a cardiovascular standpoint. The two highest risk factors is central hypertension and type 2 diabetes, followed by obesity, and then there's the rest of the risk factors. But you know, hypertension affects African Americans, a large amount of African Americans, period. So, and we see that on a daily basis.
All right, so many of our patients without primary care providers have been referred to our practice through the Sarasota Memorial Inpatient Service, the Emergency Department, as well as the Heart Failure Clinic. We are able to provide services to patients without medical insurance through the Community Health Clinic. As you can see, we have 103 referrals from Newtown, 36 of which are cardiology referrals. In addition, we have formed partnerships with multiple other organizations to address the healthcare needs in this population. As you can see, we work with Good Samaritan Pharmacy to provide medications at little to no charge to patients who are below the 200% poverty line. In addition, we work with all of these organizations, such as the Public Health Department, to provide subspecialty services for patients with hepatitis C. To date, we have prevented 39 hospitalizations by starting this practice. All right, so we provide several on-site services at the clinic. One of the most important is providing financial services. So as you can see, out of the 104 patients that were screened for financial aid, almost half of them qualified for assistance, financial assistance programs, such as disability, Medicaid. We've been able to establish these healthcare assistance programs for a large portion of our patients. In addition, we have an in-house phlebotomist who provides laboratory services. We also work in collaboration with the Sarasota Memorial Hospital pharmacy residency program. So we have a pharmacy resident as well as a pharmacy attending in the clinic who provide education about medications, assist with finding the lowest cost medications, and just generally counsel and provide education to our patients regarding their medications. We also work closely with case management, and we also have legal aid. We've recently achieved a partnership with the legal aid of Minnesota, which is one of the 3 medical legal partnerships in Florida. With their assistance, we're able to provide free legal counseling on issues that impact health. So like you know, many of our patients, they have socioeconomic issues that go far beyond their medical needs. Issues like homelessness and legal status, things like that. Currently, we're working to provide nutrition classes by working with the All Faiths Food Bank. We're also working with a Sprouts food truck to provide nutritional support for our patients, such as vegetables and fresh fruit. They call Newtown the desert of fresh food because there's not very many grocery stores and areas for patients to access quality, nutritious food. So far, our patients have been very appreciative of the services that we provide, and it's really a rewarding experience to provide healthcare to patients who need it most.
So we have a few cases that we'd like to present to you just to show the complexity of the type of diseases that we deal with on a regular basis. So first case, this is a 55-year-old African-American male. He presented to the clinic in August of last year to establish care. He also had a chief complaint of pain in his left leg, left lower extremity. So the pain, he described it being in the anterior part of his thigh, and it also radiated down to his calf. It was like a throbbing sensation, so it wasn't constant, like a throbbing type pain, associated also with some tightness, some mild swelling, and some tingling. Tingling, paresthesia is another word for tingling, for those of you. Tingling was in his toes. So the symptoms were really brought on by exertion, essentially. So in order for, he didn't have transportation. His only motor transportation was riding a bicycle, which he didn't have to go far. But every time he did ride his bike, he would complain. He said he developed this leg pain, and it was relieved with rest. He would stop and rest for about 10 minutes and then get back on his bike and continue on his way. Now, he denied any other associating factors such as chest pain, trauma, or recent surgery, or back pain, or even any weakness. But he did report some shortness of breath, which he attributed to his cigarette smoking. And we asked him multiple times, is this shortness of breath, does it get worse when you ride your bike, or does it get worse upon exertion? He denied it each time we asked him. So now as far as his history, so he had a history, has a history of uncontrolled hypertension. This was diagnosed and treated 9 years ago when he was incarcerated. So of course, when patients are incarcerated, they get their medications in the prison, so they take them on time, they take them every day. Of course, you expect compliance then, right? So when he was released from prison, he stopped taking his medications, and he hasn't been taking it for quite some time. He also has a history of GERD. Now, as far as his family history, what was relevant, his mother does have hypertension and diabetes, and going to cardiovascular risk factors, his younger sister has coronary artery disease. As far as for his social history, he smokes about a pack a day he's been smoking for about 40 years, which is quite a while. He also drinks about 3 to 4 beers a day, and he's also been drinking for the past 30 years as well. He does use cocaine occasionally. He didn't want to tell me this at first, but I had to pry and I got the information out of him. Actually, his mindset was he didn't think cocaine was that bad for him. Kind of blew my mind, but so he does use cocaine occasionally. Now, he does live in a house as well as with 10 relatives, and he is the head of the household. He's the oldest sibling, so a lot of that factors in because it causes a significant amount of stress. And stress is also one of the risk factors for cardiovascular disease. Now, as far as his occupation, he's a maintenance worker. Now, when he came into the clinic for the first time, he was very hypertensive. He was 170s over 90s. We did check his blood pressure again, and it was 155 over 102. That was, like I said, 5 minutes later. His heart rate was around 93. Respiratory rate was, although on the upper side of normal, it was 20, and he was sitting at 97% of room air. Now, his height, he's a little shorter than me. I'm 5'11". I do round up to 6, but I'm 5'11", so he's 5'9", and he's slightly overweight at 26 for his BMI. Now, as far as the physical exam, as I said, he's overweight. For his cardiovascular, what was pertinent, his pulses, checked his pulses multiple times. His pulses were absent on his left leg, on the posterior tibialis as well as the dorsalis pedis. I could not palpate a pulse on him. And his calf was tender, on his left calf was tender upon palpation, and he did have some decreased internal hip rotation, but these were bilaterally. So, and as far as his overlying skin, now he didn't have any rashes, any ulceration, any changes, or any hair changes as well. Now he wasn't a hairy individual in the first place, but that's really important when patients are complaining of pain, especially lower extremities. We want to make sure there's no skin changes, any rashes, or any cuts or anything. So, as far as labs that we got from that first visit, as you can see, his liver enzymes, his AST was mildly elevated, 55. His LDL is 154. Now, we did check an ankle brachial index, and you'll see that this was completed in October. He came in August, and this factors into part of some of the challenges that we meet with on a regular basis is his non-compliance, essentially. We ordered the ankle brachial index on our very first visit, but with persistence of calling and trying to follow up with him, we finally got him to go in and get this done, and so it was done in October. And it did show that he did have some severely decreased blood flow. So it was at 0.41. The right leg was normal. So this is his EKG. You may be able to see it from far away, but you do have some for the cardiologists out there who read EKGs. You do have some small R waves in 2-3 and AVF, which and as well as you have a small QA in AVL. So, he does have a left anterior vesicular block. He's got some early repolarization abnormalities in the anterolateral leads, but otherwise, this is a relatively benign EKG. It's a relatively normal EKG. And so I put his chest X-ray up here just for completeness sake because he does smoke, and he is very hypertensive, and he is not compliant. He's uncontrolled hypertensive. But as you can see, there's no signs of COPD, and there's really no signs of cardiomegaly on his chest X-ray. Now, we followed up, of course, with a CTA, and as you can see, this was done in January. So it was kind of difficult to get him to really follow up to get these procedures done. But here, so you can see, right here is where we're looking at the femoral artery, and then you do have complete, the report read as chronic total occlusion, which means that deep femoral artery was completely blocked. And you can see here, also noted, he has extensive calcifications. All the white part of here in his arteries is just calcifications. Calcium just build up in the artery wall. And here, of course, where we're looking at, this is what's causing his lower extremity pain, is this femoral artery right here, which you can see is just almost completely blocked off. Now, the report also did indicate mild stenosis pretty much generalized. It was in mild stenosis in his kidneys, mild stenosis in some of the arteries in his abdomen, of course, and then some mild stenosis on his right side. So he just has really, really bad peripheral vascular disease, essentially. So our number one assessment for him, of course, was peripheral vascular disease. We did start him on initially atorvastatin 20 milligrams before we got some of the studies. We started him on 20 milligrams. We titrated up to 40 milligrams. Also, we started him on aspirin. We did refer him to vascular surgery as well. Now, for his blood pressure, we started him on lisinopril and amlodipine. And each visit that we saw him, we really tried to reiterate lifestyle changes, with exercise as tolerated, because he does have his left lower extremity pain, as well as, low cholesterol, low sodium diet. Now, for his coronary artery disease, although he does have the shortness of breath, and he says it's related to his cigarette smoking, that for us that's a red flag, With his really bad peripheral vascular disease, his family history of coronary artery disease, we really wanted to refer him to a cardiologist, also to see if he could have a stress test. Now, like I said, for his high cholesterol, I know it says 20 milligrams there. That's where we started out, but it was actually titrated up to 40 milligrams. Now, again, with his shortness of breath, we did encourage smoking cessation, and then for his polysubstance abuse, or in other words, his cocaine use, we reiterated that as well on each visit. You got to stop doing cocaine. You have to stop doing cocaine. And then for his reflux, we did omeprazole. Now, he did receive his flu shot, but for the colonoscopy, we're still working on that one. So I put this here just so you can see, essentially, each visit, his blood pressures remained elevated, essentially, which just goes to show that he essentially just wasn't taking his medications. We could have added more medications. A lot of patients have, 3, 4, 5 blood pressure medications, and sometimes that's needed. But the thing is, if you don't take your medications, your blood pressure is going to be high as well. So we didn't see any need to add more medications. We wanted him to take them in the first place. But the good thing is he is very honest with us and he is upfront with us. For the first couple of visits, he said he never even filled the prescription. So, it's really important that you establish relationships with patients so that you can know how to treat them. Also, he did miss some of his clinic visits because that's really important as well. With patients who have really advanced disease, you really want to follow with them regularly. And so he never saw the cardiologist, and he continues to smoke and drink, although less. So now this right here is a study that I included. This goes over, it's a sub-analysis over the study, the INVEST trial, which essentially is a trial that was comparing calcium channel blockers, specifically verapamil, with control of hypertension with non-calcium channel blockers. So what this study looked at was patients who had peripheral arterial disease or peripheral vascular disease, as well as coronary disease, versus patients who did not have peripheral vascular disease. And what the study showed was that patients who have peripheral vascular disease have had a 26% increased incidence of the primary outcome, which was death from such as a stroke or an MI, whose blood pressures were not controlled compared to patients who did not have peripheral vascular disease. So that just goes to show it's really important for especially this patient, that he takes his medication and we get his blood pressure under control. And the next case, my colleague will present.
All right. So in our Newtown clinic, we consistently aim to reduce the risk of cardiovascular disease through primary prevention. One of my clinic patients is a 67-year-old female with no past medical history of cardiovascular disease, but with multiple cardiovascular risk factors. So she initially presented to Sarasota Memorial Hospital this past September 2017. She was presenting with symptoms consistent of 10 days of this severe, sudden onset, 10 out of 10 headache that was frontotemporal in distribution on the left side with radiation to her jaw. She denied any vision changes during this headache. She denied any cardiac, any chest pain, palpitations, or shortness of breath. So physical exam, or her past medical history, is significant for type 2 diabetes with retinopathy and neuropathy, which has been present for 15 years, as well as long-standing hypertension, for which she is on a 4-drug regimen to control her blood pressure. In addition, she has GERD. So her physical exam on this admission was significant for a heart rate of 101, a blood pressure of 182/91. Her BMI is 45, which is consistent with morbid obesity. She was presenting it to the hospital in mild distress, holding the left side of her face. She had pain to palpation of the temporal region. However, otherwise her exam was within normal limits. There was no focal neurologic deficits. Cardiovascular exam, there were no murmurs or rubs, although she did have distant heart sounds due to her phenotype, just the body habitus. So otherwise, her neurologic exam had no gross deficits. So during this hospitalization, we had labs that were significant for an elevated ESR, or a SED rate of over 100, as well as an elevated CRP. These are inflammatory markers that suggest along with her symptoms, a diagnosis of possibly temporal arteritis. So she had this biopsy done, and that came back negative. In addition, she had, her other lab work was unremarkable. So we did some imaging during this hospitalization, and as you can see, we performed a CT scan and MRI during this hospitalization. The CT scan on the left shows chronic lacunar infarct in the right cerebellar hemisphere. So the lacunar infarct looks like a little pool of dark liquid. This is indicative of a chronic ischemic change. And then the MRI flare also shows a lacunar infarct in a different region with a rim of gliosis, which is white matter change suggestive of ischemic injury, chronic ischemic injury, which could be due to hypertension, microvascular disease. Otherwise, she had negative ANA and negative anti-CCP, which is the markers that are associated with an elevated SED rate. They indicate lupus or rheumatoid arthritis, so those markers were negative. Other labs were unremarkable. Patient denied ever having a history of a stroke or stroke-like symptoms. So really, she just had this chronic ischemic change that has been, that wasn't symptomatic. So essentially a silent cerebrovascular accident with no history of clinical stroke. So when she presented to our clinic, we worked to aggressively modify her coronary artery disease risk factors, including tighter management of her glucose. So she was started on a basal bolus insulin. She received nutritional guidance, and she was referred to the diabetic clinic at this hospital, which she was compliant with. She's been working very hard to, change her diet. She was very scared when she found out about the stroke. Actually, she reacted like, I want to live for my grandkids, and she was very motivated. So unlike Chris's patient, she was very compliant, and she followed with me every month. So in regards to her hypertension, we continued her 4-drug regimen. We up-titrated the doses as tolerated. She was also referred to a cardiologist. She has a history of stroke, for which she was started on Plavix and aspirin. For her dyslipidemia with elevated low-density lipoprotein, we started her initially on a low-dose statin and up-titrated to a high-dose, atorvastatin. And in regards to, she had these chronic symptoms of aching in her shoulders as well as her pelvic area. And with an elevated ESR, she was referred to a rheumatologist who diagnosed her with polymyalgia rheumatica. She responded wonderfully to steroids with improvement of symptoms. She had no stiffness or aching sensations, but the prednisone was tapered from a high dose over the course of several weeks. Every 3 weeks, she would go down 10 milligrams, and then she was discontinued eventually. However, when we discontinued the steroids, she developed symptoms again of the stiffness and pain, decreased mobility, so we restarted her on a low dose of prednisone, 5 milligrams twice daily. In regards to morbid obesity, again, with the polymyalgia rheumatica, it makes it quite difficult for her to be mobile, to lose weight, to increase physical activity. This has been a chronic, ongoing process. So we continued, with counseling regarding lifestyle modifications, dietary changes, and recommendations regarding her diet is really what we targeted. And then she received prevention with the flu vaccine this year. As you can see, the modifiable risk factors for coronary artery disease include hypertension, hyperlipidemia, diabetes, as well as smoking. So our patient did not smoke, but she had all 3 of the other risk factors. So her blood pressure, you can see the trend improved from initial systolic of 180 down to 135 with up-titration of her medications. We went up on the carvedilol. As for her diabetes, we achieved tighter glucose control with lower sugar readings, as well as a decrease. We saw a decrease in the hemoglobin A1C from over 10, 10.8, down to 8.8, and that's on steroids. So that's saying a lot in regards to her compliance. In regards to her SAD rate, it continues to be elevated. We've recently tapered her off the steroids, but it has gone down a little bit, from 109 to 91. As for her lipids, her LDL decreased from 218 down to 82. So we saw significant improvement in these. So again, in regards to her modifiable coronary artery risk factors, we were able to achieve greater control of her risk factors, and using the Framingham Risk Score Calculator, which calculates the 10-year risk of a coronary cardiovascular event, the initial score went from 17 to 12, and the 10-year risk reduction showed an improvement from 32% risk down to 15%. Again, we still have challenges even with the most compliant patients. Diabetic management in patients who haven't had consistent follow-up, there's a lot of difficulty achieving glucose control, including just carb counting is very difficult for a lot of our patients. So we actually have a certified diabetic educator in the clinic who provided education to our patient. She went to the hospital. She was told she was able to eat, most of what she wanted to in moderation, which made her happy because she was very strict about her diet once she found out she had a history of a stroke. In terms of management of polymyalgia rheumatica, this posed some difficulty with her diabetes because without steroids, she was grossly decompensated. She had a lot of aching pains in her pelvis and in her shoulders, and she was limited with her physical activity. However, on steroids, she felt significantly better, but it was more difficult to achieve tighter glucose control. Steroids cause elevated glucose levels. So there's always the balance. It's like a double-edged sword with steroid therapy in diseases like these, inflammatory diseases. In terms of her morbid obesity, we're really just working on nutrition and getting her to be more active as much as she can. And then one of the amazing things about our clinic is she was able to address some chronic medical conditions which she hasn't had taken care of in years. So we were able to refer her to a rheumatologist, a cardiologist, as well as an ophthalmologist because she's had this retinopathy and decreased vision in one eye, as well as a cataract. So she's finally gained access to services that she previously didn't have access to. And then, of course, we continue with medication assistance to those who can't afford medications. And there have been studies, interestingly, that link inflammatory markers in inflammatory diseases such as lupus and rheumatoid arthritis with accelerated atherosclerosis and increased morbidity and mortality due to cardiovascular death, essentially. So not so many studies have been done addressing this in polymyalgia rheumatica specifically, but there have been small studies that follow patients with polymyalgia rheumatica on steroid therapy, so newly diagnosed, started on steroids, and they trend the CRP, which is an inflammatory marker, and found that with prednisone therapy, the C-reactive protein goes down, which is associated with decreased endothelial fragmentation, and it promotes endothelial repair. So a lot of these endothelial damage markers are elevated when the CRP and ESR are elevated. These are inflammatory markers that show that it's just hard for the repair to happen while they're elevated. So, but we need more conclusive, larger randomized studies, obviously, to confirm whether or not there is a cardioprotective effect of a short-term dose of steroids. All right.
All right. So our last case that we're going to present is a very complex case. So this one was a 31-year African-American male who presented to the clinic for a hospital follow-up and also to establish care. However, he did have a chief complaint of dysuria for 1 week. Now, he has a history. Initially, he had cardiomyopathy. He had a heart failure with ejection fraction of 15 to 20%, which was diagnosed in June of 2016. He came in then, at the time, he had a BNP of 9,240. He also had a history of ischemic stroke that following in November in 2016, where during that hospitalization, he did receive TPA. Also in September, he was found to have a non-ST elevated MI, also known as a STEMI, as well as hypertensive urgency. Now, he did have a nuclear medicine stress test, and the stress test did not show any reversible ischemia. However, it did show a fixed defect, which was noted in the infraapical region. Of course, hypertension uncontrolled, hyperlipidemia, and he also had a seizure in September of 2017, so this past September, which was due to, at that time, benzodiazepine withdrawal. And so, of course, anxiety, depression, and drug abuse. And drug abuse comes from, whenever he runs out of clonazepam, he buys alprazolam, which is Xanax, he buys it off the street. Now, for his social history, he has a 5-pack year smoking history, and he has a brief prior history of heavy alcohol use, but he quit 2 years ago. He also has 5 young children, which he takes care of. So just for completeness' sake, I put up here his MRI from his stroke back in November 2016, and thankfully he didn't have any residual deficits that I appreciated. But you can see here, this is the huge infarct here. You can see the magnitude of it. We didn't appreciate any deficits in him. But this right here, where the stroke is in a precentral gyrus, also called the motor strip, which controls motor function. So as you can see, he takes quite a few medications, but he is on the optimal medical therapy for his conditions. And these are quite a few pills to take, especially at the age of 31. Now, when he came in when we saw him in the clinic, he came in actually normal tensive, blood pressure 137 over 88, heart rate was in the 80s, respiratory rate was around 18. So he's also, his height is slightly shorter than me as well, as 5'8". Also, his BMI he's obese. Now, however, he is a fairly muscular individual as well. He does have some fat on him, but he's a fairly muscular individual. So now, from physical exam, what was pertinent, like I said, he is an obese male, but he was wearing his life vest, which the life vest he did receive from his initial hospital visit back in June of 2016, when he was first diagnosed with heart failure. So he was wearing it at the time when I saw him back in October. And as far as cardiovascular, I didn't appreciate any murmur scalpels or rubs, and he did not have a JVD at that time. The rest of his physical exam was unremarkable, except for what he came in for. He came in for dysuria. So for his genital urinary exam, he did have a greenish discharge noted in the urethra. It was a foul-smelling discharge, but I didn't notice any erythema or any swelling or any tenderness around the penis or the urethra. So for this gentleman, the number one assessment, of course, for him was gonorrhea. STD test came back positive for gonorrhea, tested negative for chlamydia. We did test him for other STDs, which were negative as well. And of course, for his heart failure. Now here I have an ejection fraction of 35%. That one was taken from, he's had multiple hospitalizations. So this one was taken from the most recent echo, actually. So it has improved a little bit. And of course, for his coronary artery disease and his uncontrolled hypertension, I know during the visit that I showed you his blood pressures were normal, and you'll see in a second why I put uncontrolled, but he's on optimal medical therapy. Pretty much for his pulmonary hypertension, which was found on echo as well, and his diabetes, seizure disorder, and history of stroke, he's on optimal medical therapy for those. Now, for preventative care, we did offer the flu vaccine to him, but he did decline it. And actually, in patients who have heart failure, it is important that these patients take a flu vaccine. So now for this gentleman, again, non-compliance is a factor for him. And I'm going to go over non-compliance in a little while. Sometimes we're going to have a negative connotation, but I want to explain that. So also for him, for financial resources, he is unemployed. We are in the process of getting him some disability. His application is pending, but that takes time. And that goes into some of the challenges that we meet in our patient population, because disability insurance or Medicaid, Medicare, get approved for those takes time. And in the meantime, you have to pay for your medication. You have to take your medications. So what the challenge that we're met with is trying to get our patients these medications. And so lack of insight, talking to him, he doesn't really understand how poor his health is. He feels fine, but he doesn't understand. He's 31 years old. He was diagnosed with heart failure at the age of 29. He's already had a stroke. He's had a seizure, and he doesn't really understand how poor his health is because he feels okay right now. So his lack of insight is actually a huge problem for him. And of course, his fear of needles. Now this plays into, number one, when he declined the influenza vaccine, he doesn't like needles. The second thing is, in part of his history for his previous hospitalization, he was offered a cardiac cath. However, because he's scared of needles, from what he told me, that's the reason why he declined a cardiac cath. So now I put this slide here just to show essentially his non-compliance. You can see pretty much for every visit, be it be just to the emergency department or for a hospital visit, his blood pressures were significantly elevated. They were significantly elevated. So now the only time his blood pressures were normal is when we saw him here in October. But this also goes to show that a lot of the patients who don't have insurance, a lot of patients who don't have regular access to a primary care physician, they utilize the emergency department as a primary care. So whenever they have something like otitis media, which is an ear infection, they go to the emergency room rather than something that can be treated as an outpatient. And so from this visit here, my colleague took care of him, and I'll let her take over.
So I saw this patient during a recent hospitalization in January, where I was involved in his care. So he presented in January of this year for intermittent dizziness, which he described as feeling woozy and not right in the head. These are his words. He said the episodes lasted several minutes. This has been going on for 24 hours. He denied any syncope, falls, or seizure-like activities. His last seizure, of note, was in September of last year. In addition, he denied any chest pain, palpitations, shortness of breath, really any other symptoms. He just had this kind of vague, uneasy feeling that came and went. Of note, he ran out of most of his medications 3 weeks prior. When I asked him what happened with his medications, he said he had issues with transportation, he has a history of seizures, and he's not able to get to the pharmacy. Another thing is he's busy with his social obligations. He has kids he's taking care of. So he really hasn't had time to fill up his prescriptions, was what he told me. Of note, his previous cardiac history was reviewed, which showed, this is a previous stress test showed 25% EF, and then the most recent one was 30 to 35%. He was still wearing his life vest. So physical exam on his hospital admission showed was significant for a blood pressure of 179 over 128. His heart rate was 88. Otherwise, his physical exam was pretty unremarkable, except for the obesity. He really didn't have any evidence of fluid overload, no crackles on lung exam. He had no leg swelling, no focal neurologic deficits, or no gross abnormalities. So it was essentially unchanged from clinic. Labs on this admission showed an elevated BNP just over 700, which is decreased from over 9,000. This is an enzyme that we use to monitor for heart failure. So his went down from 9,000 to 700. The troponins during his hospital stay went up from 0.01 up to 0.09. His blood sugar was 125, and his hemoglobin A1C was 6.5, which indicates acceptable glucose control. His lipid panel was checked, and that was also within acceptable limits. So his LDL is pretty low, so that's pretty good. We did do an EKG. When compared to an EKG from 2016, we looked at an EKG from 2016. At that time, there was no significant ischemia. We then compared this EKG to one from September, which was pretty much the same, except for we have deeper and more pronounced T-wave inversions between leads V1 and V6, which is concerning for ischemia, but it was the same as a previous EKG. Chest X-ray on this admission showed decreased lung volumes. And then cardiomegaly, as you can see, the enlarged cardiac silhouette, which takes up more than half of the mediastinum. And then we have some increased vascular markings, which is just the lungs look a little bit congested. There's a little bit of spotty infiltration there, likely fluid. So we repeated an echo, which we have imaging of. So on this hospitalization, his ejection fraction remained stable. So the heart function was at 30 to 35%. There was some moderate left ventricular dilation. And otherwise, he had some mild pulmonary hypertension as well. So it was essentially unchanged from October. So there we have his echo. So during this hospital course, which was very brief, his assessment was he had elevated troponins likely due to demand ischemia from uncontrolled blood pressure due to medication noncompliance. So because there were no significant EKG changes, he had no typical coronary symptoms. This was likely demand ischemia. So the blood, the heart is pumping hard against the elevated blood pressure. So increased afterload. So for his uncontrolled hypertension due to noncompliance, we restarted him on his home medications as well as his home medications for systolic heart failure. And then we added Lasix just to kind of help get some of the fluid off. We resumed his other home medications for his history of stroke, his seizure disorder, and his medications for diabetes as well. Unfortunately, the patient remained adamant that he would leave the following day regardless of our medical advice. He said he had to go back home, take care of his kids. Again, he had issues with transportation and said he can't fill up his medications at this time. So we consulted case management to help him refill his prescriptions while he was in the hospital. And then he was about to leave and walk out the door, so we really tried to expedite things just to get him what he needs before leaving. So cardiology was consulted. Again, cardiac catheterization was considered many times in the past. However, initially patient declined, but at this point we have medication noncompliance, which kind of raises concerns of the utility of intervention for coronary artery disease. So if we were going to put in a stent, what will the outcomes be if he's not compliant with medications? Basically, patient spent the night and he left the next day against our medical advice.
Okay, so this study here we decided to include for him, and I'll explain the why some parts may not exactly match up or apply. So this study essentially was the Cardia Study. It was a study that consisted of about 5,500 individuals, and it was to assess the rates of differences in heart failure among young adults. So in the study, the patients who went into the study started out between ages of 18 and 30. And these patients the ones who did develop heart failure about 12 to 18 years on the average. So the average age of heart failure was about 38 years old. Now, and our patient, of course, is 31. Now, in this study, it was about 50% African American, 50% Caucasian. And so of these patients who developed heart failure, which was only about 27 of them, 26 of them were African American. Only one was Caucasian. It was due to coronary artery disease. And so in our patient, in those 26 patients, the number one risk factor was hypertension, high blood pressure. And as you can see, and as I showed you earlier, of all the hospital admissions, except for when he came to us in the clinic, all the other hospital admissions, his blood pressures were severely elevated. 200s over 100s, over 170s over 90s. So, you know, getting blood pressure control and having it down regularly is really important for our patient, but a lot of patients in general. So now for this patient, you know, the number one thing was, of course, non-compliant, you know, due to inability to afford medications. And I said earlier, you know, non-compliance sometimes can have a negative connotation, meaning, you know, non-compliance can come with judgment. You know, why didn't you take your medications? Why didn't you do this? Why don't you do that? Well, sometimes you have to put yourself in your patient's shoes. You know, if you have 5 kids, if you have a family to take care of, are you going to choose to feed your kids or buy your medications? Sometimes you have to make a choice. You have to put yourself in their shoes sometimes. And so, of course, him, you know, like my colleague said, when he came back for his hospitalization, his most recent one, he was ineligible for invasive cardiac care, meaning a cardiac cath, because essentially you take a patient who is relatively stable and you put a stent in him. Given his history of noncompliance, you take a relatively stable patient and you make him unstable. Okay? And so, of course, the disability application is still pending. Remember what I said earlier, you know, when these applications are pending, in the meantime, you have to do everything you can to get your patients their medications. And that's where our partnerships with like Good Samaritan Pharmacy, and that's where they come into play to help us out. And of course, he's unemployed, you know, and like, as I said, he's a care provider for his five children. Now, the other thing for him, the thing that we really try to help him out with was, you know, he obtains alprazolam off the street when he runs out of clonazepam. You know, sometimes you have to make a choice as a provider. You know, your patient, if he just stops taking them, is he going to go have a benzodiazepine withdrawal and have another seizure? You know, or do you try to taper him off of these medications? And so the goal is, you know, sometimes you have to refill the medication, try to taper them down to get them off the medication rather than have them stop cold turkey. So, in conclusion, you know, overall, optimizing primary prevention of cardiovascular disease in an underserved population, it does present with many social, financial, and educational challenges. And this is aside from medical management, as we went over with our patients. And so patients without access to primary care for a long time, such as patients in Newtown community, they often present with more complex advanced diseases. You know, we've had some patients, as we stated before, we've averted quite a few hospitalizations. And that's because we've had our patients come in and we treat them and we have them come back regularly until we get them stabilized. Because some conditions aren't necessarily hospitable, if you understand what I mean, or required to be admitted to the hospital. So, and of course, and on-site, we do have an on-site multidisciplinary approach. In our partnerships, you know, we attempt to maximize resources, but it's not always, we're not always able to address all the social determinants of health in a timely fashion. And that plays into, like I said before, the disability pending applications, the Medicaid pending applications, and other constructs. So all of these factors factor in non-compliance, okay? You have to understand the word non-compliance is an overall umbrella, it's an umbrella term. It's not just a specific term for one thing, okay? But our practice has had a substantial impact on our community, Sarasota as well as Newtown community, because not all of our patients live in Newtown. We have had many patients from all parts of Sarasota come and see us, and that's because of the care that they receive here in the hospital and the care that they receive at the practice. And so we just want to continue that care and continue to make a huge impact.